Okay, we are just starting the meeting. I'm going to go ahead and admit everyone. I'll just take a second here. All right, looks like everybody who was in the lobby is in, and so we should be good to go.
Okay. Thank you, Johnny. Good morning, everybody. This is Dominic Zerlo with the New Mexico Department of Health. I'm the director for the Center for Medical Cannabis and Psilocybin. And this is the Patient Qualification and Safety Committee for the Medical Psilocybin Advisory Board. And the chair is Ian Dunn. And so I will turn this meeting on over to Ian, but just a reminder real quick, we do have cameras off and we do have everybody starting out as being muted. And so I do want to remind everyone, we do put these recordings up online so they are accessible to the public. And so please watch your language and ensure that you are utilizing appropriate language to be for us to be able to post this publicly. That is also one of the reasons why we do not have cameras on, just in the case there is something in the background to make sure that we don't have to try to go back later and blur and bleep things. So thank you, everybody. I appreciate it. And again, I will turn this on over to the chair, Ian Dunn. Ian, it is your meeting.
Perfect. Good morning, everyone. Welcome to the Patient Qualification and Safety Committee. Today, we are going to do a quick procedural motion to adopt the final first part of our committee deliverable. This will be all of our recommendations regarding patient qualification and safety. And then we will go ahead and move on to working on our second committee deliverable, which will be additional qualifying conditions before we begin accepting petitions. So we will go ahead and begin with the consolidated recommendations. I do want to notify everyone, this was sent out to the committee members, but there was one change made. All of the references to the word guide were changed to facilitator. That was just a more agreed upon term that we had found in other committees. So that was the only change that was made. At this time, I will hear any objections to adopting our first committee deliverable.
All right, and I see Eileen's hand up. All right, Eileen Brewer, I have in, wait a minute, let's see. Okay, there we go. I have enabled your mic.
Hey, good morning. Thank you so much. In the section on these recommendations regarding exclusions, the ones that really are recommended that they can never receive services even with advanced monitoring. It states that any medical conditions that are resolved can be reevaluated that are marked resolved by a doctor, but it doesn't say anything about psychiatric conditions that are resolved. You have borderline personality disorder listed here, and my understanding is that 90% of borderline personality cases do resolve within 10 years. So I would think that like this is a psychiatric condition and not a medical condition. But you're saying that they never have the opportunity to use these services, even if their condition is resolved. So I was wondering why that was and if that could be updated. Thanks.
I have never heard of borderline personality disorder being marked resolved. It could be marked treated with, depending on the person, there's a number of different medications because there's not a specific outline. But in terms of like resolved as in a cure, I have never heard of borderline personality disorder being cured. Carly?
All right,
Hi,
Carly.
can you hear me?
Yeah. Yep.
Great. I don't have personal experience with borderline personality disorder, but I will say that there are plenty of disorders, diseases, conditions that are today uncurable, but that doesn't mean that people have not been cured. I have a traumatic brain injury, which is considered a chronic condition by the Centers for Medicaid and Medicare Services. But I've done experimental treatments in other countries, and I basically consider myself cured, even though it doesn't seem in the literature like that's possible. So I would like to echo that there should be some room for possibility for people to become eligible again.
All right, and next we've got Kate
Ian,
Hawk.
Ian, you were on mute.
Oh, perfect. I was just calling up K-Hawk, so no worries.
Okay.
Yeah, thank you. Good morning, everybody. Yeah, having worked with people, including people with all kinds of diagnoses, diagnosis is just not an exact science. So people can get stuck with a diagnosis that may or may not even be accurate in the first place. And I don't know anything that is really incurable. You know, there's things that are unlikely or more difficult, but I wouldn't say anything is incurable under the right conditions. So I'm glad we have some acknowledgement about that things can change.
All right, and then Gregory Evans.
Good morning. It sounds like we're just like going right into it. I want to make sure that we have an understanding that these blocking, like what's the term? Whatever. Like the conditions that prevent treatment are future proof. Like I understand that this stuff can and will change, especially as we adopt new qualifying conditions, which we'll discuss later today. But BPD and things in that zone have historically been so commonly misdiagnosed. I think that creating a permanent block for somebody who doesn't like, I want to allow for the ability for somebody to find a doctor that really understands them and perhaps heal from some of that negative psychological trauma, like psychological trauma from psychological care that they've received in the past by getting into true alignment with their practitioners and their care team. Where somebody may be misdiagnosed as BPD and really they just are severely traumatized. That is something that this medicine is specifically designed to help with. And I understand that going in on our first phase, we want to be really careful about like how successful we are, and and by like constraining some of the treatments, we can do that. We can like put this in a very safe container. I just want to make sure that it is future proof and that the people in this room can understand and trust that this is not concrete. This is all exploration and has plasticity. How's that?
Yeah, no, and if you guys would like to move it to tier 3, the reason why it was in tier 4 was we worried about causing emotional instability for a duration of longer than the treatment. I know that there are some studies that are looking into BPD and psilocybin use for BPD. The reason it's included as of now is because there is evidence stating that we could cause emotional dysregulation, and that's what that was there to prevent in that we discussed in the other. It's not necessarily saying like we can't, but
maybe there's a way to like put a general clause that reclassification of previous diagnosis can be modified by qualified whatever, like however we define who can change a designation on a person's psychological chart, I guess. I don't know. Just a thought.
right. And I think too, this would probably serve more as guidance, not necessarily a rule, but I think Dominic has a better clarification for that.
Thank you.
Yeah, good morning, everybody. And Ian, you actually just hit upon the point that I was going to mention, is remember that these aspects, as far as around the different conditions themselves, are part of the guidance documents, not a part of the rule. And so what the rule will consist of is just sort of what information that the clinician is going to have to provide to demonstrate that the individual does meet the criteria of whatever condition we're looking at, whether it's one of the initial 4 or conditions even in the future. And so, for example, if, with regard to, treatment-resistant depression, that it's the clinician is then attesting that this individual, that this patient has treatment-resistant depression, that they have gone through the appropriate testing to ensure that that is indeed the situation, and that they believe that as they have done their own and additional research and looking at the guidance that will be provided through some of these other documents, that they then believe that that utilizing psilocybin has the potential to be more beneficial rather than negative effects for the patient and their condition. And so remember, these are about guidance. So as far as for this aspect, this is not a set in stone. Guidance is set to be reviewed on a regular basis. There hasn't been a timeline set for that at this point. That may be something that would help with regard to some of these concerns and questions, is to say maybe, and it doesn't necessarily have to happen in here, but to potentially say these guidance will be reviewed, by this committee and or advisory board in the department, once every 2 years, once every year, whatever seems appropriate. To also look at that. So that's one of the other aspects I just want to bring up and remind everyone, this is about guidance. This portion is not necessarily set in stone. So
Thank you. And I think that's the voice that we needed to hear this morning. Regarding like the framing of this, and I think how we communicate that outwardly is very important. So thank you.
Yeah, and then I do also want to add, in that conditions line, it had said reassessment may occur for medical conditions that have demonstrably resolved and for which documentation supports sustained clinical stability. So if you've had it resolved or it was a misdiagnosis or whatever, and you've shown, I've actually just had, depression or ADHD, and they diagnosed me as bipolar or whatever the situation was, it would allow for that. I went ahead and clarified it and said reassessment may occur for medical and mental health conditions that have demonstrably resolved, just to add that extra clarification. Yeah. All right, are there any other objections in this?
Let's see. I think Eileen's hand is still up. Eileen, did you? Oh, okay.
Yeah, I mean, what Gregory said is really what I was asking for initially, and I just wanted to reflect people's concerns that like people can be misdiagnosed, and especially for psychiatric conditions where there's no like blood test you can take to find out if you have borderline personality disorder or any psychiatric condition. It's frequent for people to get misdiagnosed, so I think that helps a lot.
I do
the
want to
other thing I want to
recognize.
say. Huh?
Oh, sorry. I said I do want to
The other-
recognize, I have been misdiagnosed. I know that sometimes we do need to resolve it. So definitely I recognize that, and I'm sorry if I implied in any way that like I don't respect that. I definitely do. Especially for mental health conditions where oftentimes the diagnosis is based on subjective data, and then how the patient responds to treatment is also a big factor that's used. So it can really be a guess and check game.
Right, and that is why borderline personality disorder is resolved like 90% of the time, because it's misdiagnosed a lot. But the other thing that I want to say about guidance as opposed to like, rules, is that guidance gets put out all the time for things, and people follow that, especially in a space like this. If you look at the guidance that was put out for opiate prescribing, that is just guidance, it's not rules. every single doctor in the country pretty much follows that guidance without being flexible at all because they are afraid of repercussions. And I imagine that in a space like psilocybin, people are going to follow the guidance rigorously to the letter as they interpret it because they are afraid of repercussions from boards that would give them licenses. So even though we're saying this is just guidance and it's going to be reviewed and we don't know how often it's going to be reviewed and we don't have that yet, I would caution people to understand that guidance is still going to be considered rules by most people. Thank you.
Alrighty, thank you. And then any objections at this time to the amended version? I'll go ahead and post it in the chat. And then Jorge, you're showing the major depressive disorder document and not the
Yeah,
consolidated recommendations.
I will switch that right now. Okay. Is there a page you want me to scroll to?
Depending on what we end up at. All right, and then at this time, I'll go ahead and ask for a unanimous consent motion. If you have an objection to this, please raise your hand at this time. K-Hawk, do you have something to say?
I'm sorry, that was just a tech glitch.
No worries. Chris?
So I'm curious, good morning, everyone. I'm curious, which one of these documents are representing rules that we're implementing and which ones represent guidance?
So rules would be like in relation to licensure or fixed things that are in place. Typically, guidance is reserved for how the care is presented, the stability and that kind of thing. I think Dominic could provide better explanation than I could, but
Yeah, what I would actually say is that these are guidance, that these documents are all guidance documents, not rule-based, or not to be rule.
cool. And then I see Carly.
I was wondering how the last bullet point, active inability to provide informed consent, would be defined. I represent the brain injury community, and I fear that people could say that, oh, you have a brain injury, you can't consent to this, or you have a stroke, you just had a stroke, something like that, when this medicine could be really, really helpful for those people.
So an active inability to provide informed consent would be things like severely progressed Alzheimer's or dementia. It could be active intoxication. It could be a manic episode, but that inability to provide informed consent, if it can mean a lot of things, it just means that you have to be functionally aware of what you are accepting. We don't want to send someone into a psychedelic trip if they don't want to.
Oh yeah, so if they say, I want to do this, I agree, that works.
Right. If they can
Okay.
understand what they are being offered
Yeah.
and warned about, and then they say, yeah, I agree, then that would be fine.
Okay, cool.
Sky?
Okay. Sorry, I had my pro beads on. Um, if a clinician recommends this program, then the clinician would have made that determination, correct? This is Sky Rivers. I'm with the Santa Fe Reporter, just putting it out there. So am I correct in that? Right?
It would
Wait a minute, let me
usually
make you higher.
be the facilitator because they're the ones that are accepting that informed consent form.
Yeah,
So if they came into, for instance, an administration session intoxicated, even if the clinician said, yeah, they're good, we
right.
would still say they have an inability to provide informed consent to that psilocybin process.
I think for me, I am someone who does suffer from TBI. I fell down a flight of stairs in a manhole, hit my head, but I'm aware of everything. I don't have it to the degree where I don't understand what's going on, obviously. But for someone like me who has traumatic brain injury and wants to go into the program, if the clinician says it's okay, then there are different levels, as I think Carly was speaking of, that occurs. So that's where I just wanted the clarification. So if the clinician says, okay, they have TBI, but it's a mild or, 1 to 4 levels. I don't know how you want to work that out if you're going to put that in there. My my question would be again on this subject. Would the clinician who's recommending it, who knows the patient, be the source instead of the facilitator making the determination when the doctor who has been seeing this patient for years is saying they're fine, they're good for the
I think
program.
it has to do with the reason they would have an inability. So if it was like your instance and we were referring to a historical diagnosis, then we would refer to the provider that has been treating that for the longest duration.
Yeah.
But if it was like a current thing, I smell alcohol in their breath, that's where it would be that kind of that guide. Each clinical role that we worked out in dosage has clinical practice and scope. So it would not be within a facilitator scope to say, actually, I'm going to override a clinical decision made by the clinician or the psychedelic therapist. It would be on the original referring when it's a historical diagnosis. They each have their own little role.
Right. And then quickly, you brought up twice about, smelling of alcohol. Are we comparing someone who has an addiction to someone who has traumatic brain injury? Though someone who is sick, regardless of pain or TBI, might come in with alcohol. I don't know, or pain medication.
No,
So,
I'm comparing two instances of an inability to provide informed consent.
oh, okay. All right. That's all. I just wanted clarification. Thank you,
Yeah.
Ian. Okay.
Of course. And then Gregory.
Hey, I think you covered most of it, but I just wanted to try to clarify it, just in very simple terms for Sky, because I think this is it's one of those things that's easy to misunderstand, and it's also like in progress. Like this has not like this is still gelling, but like Ian said, there's different types of practitioners. They each have their own scope and role. There you go to one person that says you're good to go, clearance. That person's probably going to clear you based on conditions. When you get to the facilitation session, there are layers of consent through the entire process, and if you come in a state that is not acceptable per the guidelines of the program to receive treatment, that's another like time that can be assessed. But the facilitator in the session is not going to be judging your mental, like overall mental conditions. You've already been cleared for the program, you've been through preparatory sessions, you're showing up for the day. But if you're drunk, that might pause the session. I think let me know if I got that correct, Ian.
That is exactly right. Alrighty. Any other points, clarifications we can make? Cool. Then we will go ahead and move to a vote. All those in favor of adopting the committee consolidated recommendations, please raise your hand at this time.
Looks like a show of 4 hands.
All of those opposed?
I don't see any.
Perfect. With 4 yeses, 0 nos, the motion passed. Now we can get on to the fun part of today's meeting. So over the last meeting, we decided to discuss depression, and we decided to discuss neurological disorders. So to best encapsulate at least 2 of the neurological disorders we talked about were Alzheimer's and Parkinson's. So I think both of those would fit within the definition of existential distress due to a life-limiting illness. So if Jorge, you could bring that up for me. And
Okay, I
then
sure
2
will.
others that we discussed that we will go into later today are chronic headaches, was the other neurological condition. But for the first 2, we did Alzheimer's and Parkinson's. Go ahead and put that in the chat. So we'll go ahead and read this as well. Whereas existential distress associated with a life-limiting illness is a serious form of psychological, emotional, and spiritual suffering that may include death anxiety, demoralization, hopelessness, loss of meaning, loss of dignity, grief related to functional decline, and difficulty adjusting to serious or progressive illness. And whereas existential distress is common among patients with life-threatening or life-limiting medical conditions and may substantially impair quality of life, emotional well-being, treatment engagement, family relationships, and end-of-life adjustment. And whereas existential distress is not always adequately captured by traditional psychiatric diagnoses alone, as patients may experience clinically significant suffering related to mortality, identity, autonomy, meaning, and anticipated loss, even when they do not meet the full diagnostic criteria for major depressive disorder, generalized anxiety disorder, or post-traumatic stress disorder. And whereas standard palliative, psychiatric, and psychotherapeutic interventions may not adequately relieve existential distress for all patients, particularly when distress is related to loss of meaning of life, fear of death, demoralization, or spiritual suffering in the context of life-limiting illness. And whereas randomized clinical trials in patients with life-threatening cancer have demonstrated that psilocybin-assisted psychotherapy can produce rapid, clinically meaningful, and sustained reductions in anxiety, depression, and cancer-related psychological distress when administered in a structured therapeutic setting with preparation, monitored administration, and integration support. And whereas in a randomized, double-blind, placebo-controlled crossover trial at Johns Hopkins University involving patients with life-threatening cancer, psilocybin produced substantial and sustained decreases in depressed mood and anxiety, along with improvements in quality of life, life meaning, death acceptance, and optimism, with effects persisting at 6 months follow-up in substantial proportion of participants. Whereas in a randomized, double-blind, placebo-controlled crossover trial at New York University involving patients with cancer-related anxiety, depression, psilocybin-assisted psychotherapy produced immediate, substantial, and sustained improvements in anxiety and depression, with additional improvements in existential distress, quality of life, and spiritual well-being, and attitudes towards death. And whereas long-term follow-up of the New York University trial found that reductions in cancer-related psychiatric and existential distress were sustained approximately 3.2 to 4.5 years after psilocybin-assisted psychotherapy, suggesting potential durability of benefit in appropriately supported patients. Whereas secondary analyses of psilocybin-assisted psychotherapy in cancer-related distress have demonstrated acute and sustained reduction in loss of meaning, hopelessness, demoralization, and death anxiety, supporting the relevance of psilocybin-assisted therapy to existential distress specifically, rather than depressive or anxious symptoms alone. And whereas recent reviews of psilocybin-assisted therapy for existential distress and serious illness conclude that the available evidence is promising, particularly in cancer and palliative care populations, while also emphasizing the need for larger randomized trials and careful clinical safeguards. And whereas the inclusion of existential distress associated with life-limiting illness recognizes a legitimate and clinically significant form of suffering that may arise in the context of serious illness and may warrant access to regulated psilocybin services where clinically appropriate. Therefore, the committee finds that the current body of clinical, systematic, and mechanistic evidence supports the inclusion of existential distress associated with a life-limiting illness as a qualification within a regulated evidence-based psilocybin program. For the purposes of eligibility, existential distress associated with a life-limiting illness means clinically significant psychological, emotional, or spiritual distress arising in the context of a serious, progressive, or life-limiting medical condition, including but not limited to death, anxiety, demoralization, hopelessness, loss of meaning, loss of dignity, grief related to functional decline, or adjustment-related suffering. That was a lot. All right. So any discussion, questions, comments, concerns? Eileen?
I'm always first. I feel like I'm like the person who complains a lot, and I don't want to, because this is phenomenally good, and I love it. However, I do have concerns that it doesn't encapsulate all of the Parkinson's patients that you would want. The reason that we're talking about Parkinson's at all is because there was a study done last year at UCSF for it was a small study of Parkinson's patients, and the results were profound. And they did find that they were looking at existential distress with Parkinson's, and they did find that it helped. They also found that it helped with mood, cognition, and motor function. And so those results suggested that this could be the first study that showed that psilocybin could help with neurodegenerative disease as far as helping to repair the brain. And so if we get to the point where we find that, if we're just talking about existential distress and not calling out, somebody with early stage Parkinson's disease who does not yet have that existential distress, they may not be included as we would like them to be. Obviously, this is early stage work, but if we are talking about neurological diseases, we want to consider that it's not just existential distress associated with neurological conditions that makes psilocybin appropriate for these patients. Thanks.
Thank you. And I do recognize that existential distress is not the primary reason, and the new evidence is astonishing. My thing is if we try to send that over right now, I don't think the body of evidence is sufficient to just say on its own Parkinson's is qualifying, but there is substantial evidence on existential distress. So this may be not, while we can't approve Parkinson's today, right? We don't have the evidence for it. We can approve the existential distress associated with Parkinson's and kind of allow that to be an option for the provider, and they can explain those benefits to the patient. Does that make sense? And then Gregory?
Hi. This is a great crosswalk moment. The Research and Continuous Improvement Committee is already like opening up the conversation for like what we look at for next phases. And it is really a very difficult decision for me to like let this go because I think TBI neurological disorders are the highest like value grabs for actual pharmacological impact of psilocybin, 5-MeO, and other HT2A related compounds. But the way I'm seeing this, Ian, is, and what you're saying is like, let's create this little loophole where people with existential distress can start to like maybe get into some of those earlier phases, while in like our phase 2 and our phase 3 will come with deeper arguments for like actual medical treatments for neurological disorders. Is that kind of the way that you're framing this?
Yeah.
Excellent.
There is not enough randomized clinical data, but if we begin this program and we begin treating Parkinson's patients with that existential distress, and we can show our own state numbers that show that it is greatly improving motor function, then we would be on a much better path to submit, because we'll still have to submit it to the Department of Health as a qualifying condition. We'll have a much better basis than if we just try to submit it now as just Parkinson's.
Yeah, and I think the work that we can do in RACI committee to like prep those conversations could be really informative for those like future conversations. I would want to just plug found a new company that should be watched in this space. It's a company called 5 Discovery. Dr. Manesh Gurm is one of the main co-founders, and they're utilizing a synthetic modification of 5-MeO to treat specifically neurological disorders. But I think that the parallel psilocybin research could be extremely valuable for like hand-in-hand discovery. Anyways, I'm cool with this the way it is, but I think it's just important to understand that it's like definitely this stuff is not in phase 1, but I like that there's a little kind of back door, if that's okay to say.
Yeah. It allows us to create an evidence-based program while the evidence for Parkinson's is still developing, at least if they are suffering with existential distress, we can ensure that they still get treatment.
Yeah, I also can we speak TBI in that as well? Can we make sure that ends up in the language?
TBI would be accepted. So the language does
Okay.
not list a specific condition. It just
Copy
says
that.
clinically significant psychological, emotional, or spiritual distress arising in the context of serious, progressive, or life-limiting medical condition. So
Okay.
it could be related to death anxiety. It could be related to just, if you've ever gotten diagnosed with something later in life, you definitely know the anxiety. But yeah, no, this would if a TBI patient had existential distress, they would also qualify under this while the research is churning. Right. Any more questions, comments, concerns? Harley?
I think it's great. I think it can include anyone with a neurological condition, or even like Lyme's disease, arthritis, lots of different things that are chronic and distressing and existential. So I just wanted to say I think this is great. Thank you.
Perfect. Well, thank you for that. All right, then let's go ahead and take a vote on existential distress associated with a life-limiting illness. Please raise your hand at this time to adopt.
I do see 10 hands again.
Perfect. And please lower your hands at this time. All right, and then those opposed, please raise your hand.
I
0
see
no's, 10 yeses. This is adopted. Let's go ahead and move on to cluster headaches. Honestly, probably set it under that as well, but there is a good amount of evidence for this one. So
I'm opening that now.
Gregory? Had a
I was
comment?
just curious if you could speak to why you didn't include what's that other word? The other kind of headaches, not cluster headaches. The wow,
Migraines?
come on,
Migraines?
brain. Yeah, migraines. Why did we not include that language in here and just have clusters? Curious.
Honestly, the studies I were reading just listed them primarily as cluster headaches, so that's just what I had done. And because in the last meeting we had brought up a bunch of conditions, and so I had a list of what I was checking off under neurological for the next one, so it was already on my list. We can add migraines.
I really don't know. I don't have like a hard stance on it. But it's funny because it's like it's one of those things that we really just don't understand. Like, is it a neurological disorder or is it not? You know, when you get really deep into it, there is a big question mark. So I have heard some anecdotal reports of like positive effects for migraines, but also like I haven't seen like any extensive studies. I think studies are a little bit it's a hard one to hit.
I mean, is there a difference between cluster headaches and migraines without aura?
Yes, 100%. Cluster headache and migraine are two completely different disorders. There's about 100 different headache diagnoses. Cluster headache and migraine are two of the primary headache disorders. Cluster headache has different symptoms, different classification. It is a completely different disease. There are completed phase 1 studies for cluster headache. I'm not sure if the migraine study that was done at Yale was phase 1 or just a pilot study. I think it had about 50 patients. But there is more anecdotal and researched evidence for cluster headache than there is for migraine at this time. I personally know about 1,000 people who have taken psilocybin for cluster headache and are doing very well.
So in response to that, thank you for that clarification. So I have found a good number of studies on cluster headaches. So if we want to go ahead and go through this, or Gregory had a point before I just go ahead and read.
Oh, I don't think my hand was just still up. I'm looking to see if that Yale research moved to phase, but I'll post it in the chat.
All right, so whereas cluster headache is a primary headache disorder characterized by excruciating unilateral pain and autonomic symptoms, often referred to as suicide headaches due to the severity of the attacks and the high rate of patient distress. And whereas current standard of care treatments, including high-flow oxygen, triptans, and prophylactic agents like verapamil and lithium are insufficient, contraindicated, or associated with significant side effects for many patients, and whereas preliminary survey data first identified a specialized pulse dosing protocol of subhallucinogenic or low-dose psilocybin as an effective method for terminating cluster periods and extending remission, and whereas follow-up large-scale user surveys confirmed that patients reported psilocybin to be more effective than conventional treatments for both aborting individual attacks and preventing future cycles, whereas double-blind placebo-controlled pilot studies have demonstrated that oral psilocybin significantly reduces the weekly frequency of clusters attacks compared to placebo, with the benefits persisting for weeks after only a few doses, and whereas subsequent clinical research has further characterized the dose response relationship, suggesting that the therapeutic effect on headache frequency may be distinct from the acute psychedelic or mystical experience. And whereas longitudinal neuroimaging and 5-HT2A receptor occupancy studies provide a neurobiological framework for how many psilocybin may reset the trigeminal autonomic reflex through modulation of the hypothalamus and serotonin system. And whereas the accumulated clinical signals and safety profiles from these trials indicate a low risk of serious adverse events where administered in controlled or monitored settings. Therefore, the committee finds that the current body of clinical, systematic, and mechanistic evidence supports the conclusion of cluster headaches as a qualifying condition within a regulated evidence-based psilocybin services program, with the references below. Questions, comments, concerns?
I think this is amazing and I really appreciate it. I don't know how we managed to do this. I know that it's going to be something for a different committee than this, but I do want to caution that treating cluster headache is very different than treating a psychiatric condition, because the dosing needs to be more frequent, except it's lower dosing usually. So I don't know how we go about communicating with other committees that, hey, this is something that we're recommending, but there needs to be training around it so that people aren't treated inappropriately and then think it doesn't work for them. That's my only caution. Thanks.
Thank you. Gregory?
I just wanted to augment that last comment because like this is something that we're going to see when we get into medical treatments for pain, where patients are going to need 1 or 2 grams, like a significant dose, like every couple days for a period of time based on the research. And it's like not really something that the format of this program can handle. But I think it is something to be considered about like safety and containers of use and home use and like stuff like that we haven't really been able to get into, and I don't think we will get into in this first phase, but like man, that's a fun one to untangle. But yeah,
It will
complicated.
be. I definitely have some ideas, and we'll get into that more in the other committees. But yeah, no, that will be an interesting problem to solve. Questions, comments, concerns on cluster headaches? And then thank you, Gregory, for putting those migraine studies. I will review them and then prepare a migraine document for the next meeting. All right, with no further discussion, we will go ahead and vote on cluster headaches. All those in favor, please raise your hand.
I see 8 hands up.
All right, please lower your hands. And then all those against, please raise your hand.
I see 0 hands raised.
Perfect. Alrighty, Jorge, now the document you've been waiting for since the beginning, major depressive disorder.
Okay.
Alrighty. So, well, I understand in phase 1, we're going to work with the legislative conditions, and so that means allowing treatment-resistant patients to go first. I personally am not a big fan of forcing patients to go through classical pharmacological treatments, especially when the evidence says that depression doesn't just they haven't only evaluated treatment-resistant depression, they've also evaluated major depressive disorder. So I think this would be something that we could look into. So Whereas major depressive disorder is a prevalent, recurrent, and potentially life-threatening psychiatric condition associated with substantial functional impairment, diminished quality of life, and elevated risk of suicide, and remains the leading cause of disability worldwide. And whereas standard treatments for MDD include antidepressant pharmacotherapy and psychotherapy, are limited by delayed onset of action, incomplete response adverse effects, and high rates of treatment resistance, leaving a significant proportion of individuals with persistent or debilitating depressive symptoms. And whereas high-quality randomized clinical trials demonstrate that psilocybin-assisted therapy produces rapid, clinically meaningful, and sustained reductions in depressive symptoms when administered within a structured therapeutic setting, that includes psychological preparation and integration. And whereas in a multi-site, double-blind, active, placebo-controlled phase 2 randomized clinical trial involving adults with major depressive disorder, a single 25 milligram dose of psilocybin was associated with a large and statistically significant reduction in the Montgomery-Asperger Depression Rating Scale. Scores compared with niacin with antidepressant effects, evident by day 8 and sustained through 6 weeks, accompanied by significant improvement in functional disability and no serious treatment emergent adverse effects. Whereas these findings are consistent with an earlier randomized earlier randomized controlled evidence from a trial conducted at Johns Hopkins University, in which 2 psilocybin sessions combined with supportive psychotherapy produced very large effect sizes, rapid symptom reduction, and high rates of clinical responses and remission at 1-month follow-up in adults with major depressive disorder. And whereas converging pharmacological and translational evidence indicates that psilocybin acts as a rapid-acting antidepressant through serotonergic 5-HT2A receptor agonism and downstream neuroplastic mechanisms, including the modulation of glutamatergic signaling, synaptogenesis, and brain-derived neurotropic factor related pathways, providing a biologically plausible explanation for the rapid onset and durability of antidepressant effects observed in clinical trials. And whereas the magnitude, rapid onset, and durability of antidepressant effects observed with psilocybin-assisted therapy compare favorably to existing pharmacological treatments for MDD. Therefore, the committee finds that the current body of clinical, systematic, and mechanistic evidence supports the inclusion of major depressive disorder as a qualifying condition within a regulated evidence-based psilocybin program. We made it, guys. So, questions, comments, concerns, discussion? Yeah, I figured this would be the most pretty easy to agree on, but Carly?
So this doesn't require someone to go through many rounds of antidepressants and things and fail at those first. Is that correct?
No.
Wonderful.
Gregory?
Dang it. Bravo is all I was gonna say. Well written.
Thank you.
Man, I'm sorry.
It's okay. It happens to the best of us. Alrighty, all those in favor of adopting major depressive disorder, please raise your hand at this time.
I see 7 hands raised.
7 yes. All right, please lower your hands at this time. All right, all those opposed, please raise your hands.
I see no hands raised.
Perfect. Major depressive disorder is passed. And those are the 3 conditions that I had prepared for today. So what do you guys want to discuss next time?
Could
Carly?
you fill me in? I was invited to this by Bob from Clusterbusters. And I just would love to hear some context. Like, what are these meetings? What are we trying to do? I just kind of came in and gave my opinions, but
Yeah.
your question that you just asked, like, can you prime me, please?
Yeah, so we are the Patient Qualification and Safety Committee. All of the committees work with the Medical Psilocybin Advisory Board to allow more community input from people around the state of New Mexico in the development of this program. I've said since the beginning, we have 7 very smart board members, but they will never compete with the intelligence of the entire state of New Mexico. So I've always opened these meetings up to the public and allowed public participation. In regards to my specific question, I was just asking what other qualifying conditions do you think we should discuss? have, considered what would you like me to look into. I know we brought up migraines during the meeting, so we can definitely look at that. Just kind of hearing from the community.
And then you take the considerations of the community to the New Mexico Department of Health Psilocybin Committee. Is that
So
right?
I'll take all of the so I'll take committee recommendations. The committee recommendations go to the Medical Psilocybin Advisory Board. We'll discuss them. If they agree, they get sent to the Department of Health. If they do not agree, they get sent back down to committee so that we can make whatever changes that we need to. And then we go from there.
Okay, awesome. Thanks so much.
Perfect. Thank you for joining us. Gregory?
Oh yeah, thank you, Carly, for showing up. I think that the communities that you represent are underrepresented in these meetings, so I'm really happy to see you here. As far as things that we could get into, and to clarify, we're probably looking at year plus out for any action on these things, if I'm not mistaken, right? We're pretty set for what's happening in December.
Right.
But I think digging into the guts of SUD and PTSD and then seeing how we can fold in complex PTSD could be pretty interesting. And combined treatments for multiple disorders. And then the other stuff that sits on my radar would be chronic pain, as I think pain management is hugely important, understudied, definitely something that we could open some doors on potentially. OCD and eating disorders are also kind of on my tag list.
All right. Well, I definitely know we can get started on migraines. PTSD and CPTSD, it would depend on how the department defined it, but usually, like in the DSM-5, they're the same. I know, unpopular. I don't agree with the DSM-5. I'm just saying.
Did they not? I thought they just changed it.
Did they just change it?
Well, I mean, that might be just.
I mean, it's not a
couple
diagnosis.
weeks.
It is referenced in the DSM-5, but it's under the category of PTSD. But in the ICD-11, it differs. Oh, that's so fun. Yes, we can definitely talk about CPTSD. They like to make it so fun for us.
Yeah, I mean, I think it would be fun to have some just exploratory sessions.
Definitely. All right. So let's definitely look into CPTSD, migraines, and chronic pain at the next meeting.
Can anyone remember who was talking about treating chronic pain in the last meeting and making sure that they're on this? Can anybody remember? I can look it up.
Lida Fatime and
Yeah, I was gonna say
in the chat.
She just put it in the chat.
Ah, there you are. Hi. Do you think it's possible that we could send Eileen home with some homework? I'd really like to hear like direct frontline in work that people are doing.
Yeah, I can do homework. What do you need?
How do everything we have on pain management, treatment protocols that there's no way we can possibly do.
Oh.
And
yeah, there's
mechanisms
no way,
and yeah.
Yeah, I can get you a consolidated report on it for the next meeting if you'd like, or before the next meeting.
Not me. I'm just a nerd.
Yeah, just send it to Medical Psilocybin at
I just put in a chat, Ian.
cool.
You got it.
Alrighty, and then we can also go over that. Perfect. So I am actually very busy for the next 2 weeks, but how does the 25th sound for everyone?
Let me take a gander at our calendar here.
May 25th is Memorial Day.
May 26th.
Oh, 26th.
Think that should work. At still 9?
Sure.
Cool. All right, yeah, that looks good.
Perfect. Well, thank you everyone for coming. I really appreciate all of your voices, and to our newcomer, we welcome you back. Please check out the department website and see what other meetings we have. I know training and education is on Friday and the dosage is tomorrow. They're working on preparation sessions, integration sessions, and other things at the next meeting. So we look forward to seeing you more. Thank you all for joining us today and spending your Monday with us. We really appreciate all of you, and have a great rest of your day.
Thank you, everyone.